So our last presentation does have to do with the end of a person's lifespan. We have Teresa Donalson and Janet Elder, who are going to be presenting on the newly developed and in the process of developed palliative care toolkit that would be available to everyone across sector. So, Janet Elder. Janet is a graduate of the University of Windsor with a Bachelor of Science degree in nursing. She has held her palliative care certificate since 2006, with over 30 years' experience working in developing her knowledge in hospice palliative care. She has applied her knowledge and passion to positively impact the illness experience for patients, families, and care teams. Janet has been in her present role since 2019 as the Palliative Pain and Symptom Management Consultant and Educator for Windsor, Essex through the Palliative Pain and Symptom Management Program for SW, Southwest, is that Southwest? And has been the past chair of the Palliative Care Consultation Network. Previously, she worked on the Hospice of Windsor. She worked at the Hospice of Windsor and held a number of roles, including the role of palliative liaison nurse. Janet proudly serves as the co-chair of the Provincial Intellectual and Developmental Disability Palliative Care Network, working on an IDD palliative care resource guide and toolkit, which is the presentation today. She is also one of the clinical co-leads for Ontario, is that OH West, Ontario Health West, since 2016. Okay, Teresa Donalson is one of the committee members for CRPADD. She's an area administrator with the Community Living Dufferin and a compassionate, dedicated leader with over 30 years of experience in the developmental services sector. She holds a degree in disability studies from Metropolitan University and is deeply committed to enhancing the quality of life for individuals with intellectual and developmental disabilities, particularly in the context of end-of-life care. Teresa has worked to bridge the gap between medical community and developmental services, advocating for inclusive, person-directed approaches. She had spoken to diverse audiences across Ontario, championing policies that recognize and uphold the right of individuals with intellectual and developmental disabilities to direct their own end-of-life journey. So please welcome Teresa and Janet.
All right, so thank you everyone for inviting us here today. So we're excited to kind of share a little bit of information with regards to the resource guide and toolkit that we have been working on for at least the better part of 3 years now. So happy to be here today. Next slide. So this is just a quick little picture. So of course, you know, Teresa and I and Paula, thank you for the lovely introduction. So we appreciate that. Here's our contact information should you want to reach out to us if you have any questions. So we're just going to kind of start off a little bit, just talking a little bit about what palliative care is. So if we go on to the next slide, please. And whenever I do a presentation, I always kind of like to include this particular slide. So those of you who may or may not be familiar with Cicely Saunders, but she was one of the hospice pioneers in the UK who did a lot of work when it came to palliative care. And she's known for a lot of her quotes, but this one always kind of really resonates with me. So how people die remains the memory of those that live on. And that's why we're all here today, because we want to get it right. So if we get it right, you know, family members and even us as the care team, you know, we kind of have those memories where we have that satisfaction that we did a really good job in optimizing that person's quality of life and really doing, you know, a good coming together to really support that individual. But if we don't do that, it kind of really leaves us with that moral residue. So that's why we're all here today, to kind of be able to learn from that. So when we talk about palliative care, it's really about, it's an approach to care, that how we can improve the quality of life. And I've recently just heard even a phrase as how we maximize that person's quality of life. So not only the person, but as well as the family as well. And we're looking at palliative care, we call the person and family the unit of care. And that's really where we focus our attention to really, you know, help support anybody with a life-limiting condition, or even now we refer to it as a serious illness. So how do we do that? By really that early prevention, kind of relief of suffering by means of that early identification. So really identifying when somebody would benefit from that palliative approach to care, using our assessments, really making sure that there's treatment of pain and other issues. And again, looking at when somebody has a serious illness, not only does it impact them in the physical domain, but how it affects them in the psychosocial and the spiritual domains as well. All right.
So we move on to talking about the distinct palliative care needs of people living with an intellectual developmental disability. So people who have an intellectual developmental disability are not always in family homes. They live in many different settings: supported independent living, congregate care, group home, host family. And so there's a lot of different options. Quite often they're different than the general population. And the diverse living arrangements and support needs create challenges in accessing services, because some people are seen as already having service and not qualifying for the same things that you and I would. But our take-home message from today is that it can be done. We can successfully and positively provide palliative care services within the DS sector. And the goals of this toolkit is to bridge the gap and make the process smoother for everybody. So quite often, there's inequitable access to palliative care. People with IDD lack equitable access to the services that are out there. Most intellectual developmental disabilities, their etiologies are life-limiting in and of themselves. So quite often there's the diagnostic overshadowing, where it's deemed to be a disability-related issue, where in reality it's a medical issue. And this leads to healthcare disparities, resulting in high use of emergency department, more likely to make repeat visits to the ER within a short period of time. This often leads to late identification. Late identification limits treatment options. Limited treatment options quite often leads to premature death. So none of this in these inequities are doing they're doing a huge disservice to the people that we support. So people with intellectual developmental disabilities would benefit from a palliative care approach, the opportunity to positively impact their lives and their experiences. But in order for that to happen, we need provider competency. And that's referring to, within the developmental services sector, we need to learn and get comfortable with the concepts of palliative care. And we need the healthcare sector, palliative care supports, to understand people with intellectual developmental disabilities, and for all of us to come together into an intentional team that's combined developmental services, healthcare, and palliative care specialists, because that's how the people we support are going to truly get the quality of healthcare that they deserve. We have limited number of people in Janet is one of the exceptions, that have limited information, understanding around developmental disabilities. And so that leads to challenges, because if they don't understand that side of the person that they're caring for, then it doesn't often lead to quality outcomes. Existing palliative care guidelines and tools aren't directly transferable to people with intellectual developmental disabilities to provide quality information so that appropriate care can be provided. And this is one of the biggest pieces of the toolkit, is finding tools and ways to bridge the gap between the existing tools that are used in palliative care and tools that will be used effectively for people with intellectual developmental disabilities. We have people we support are quite often invisible to palliative care providers, not really in the purview. So none of the things that are currently out there for the general population transfer well. We are quite often in the developmental services sector underserviced. And having these things and not identifying early and not having the quality level of service often leads to hospitalization and quite often people will pass in hospital where they would have preferred to have a death at home with the team who knows them best, but due to lack of services, they end up having to go to hospital for care that they should have received alternatively. So our current state, access inequities, we have siloed, fractured care coordination, primary care deficiencies, avoidable emergency department transfers, quite often diagnostic overshadowing, like I spoke about before, where the disability is viewed as the reason for certain symptoms, where there's actually an underlying separate medical condition that's not being addressed. Late identification, late referrals, late treatment, potentially early death as a result. Pain and symptoms unidentified, undermanaged, assumed inability to adhere to a treatment plan where people are denied the opportunity to receive certain treatments because they're deemed to not be able to follow through or understand the treatment options that are provided. Assumed inability to understand the concept of illness and death. Grief is unrecognized, inadequate grief and bereavement supports, assumed inability to participate in advanced care planning or healthcare consent, and the legal and ethical issues, including consent and supported decision-making. All of these are pieces that led to this group on the committee to come together to develop this toolkit.
All right. Thank you, Teresa. So pretty well what kind of Teresa has been alluding to, there's been, it was recognized back in, well, before that though, but there was a group of individuals who came together in 2019 who really recognized that the inequities and the lack of equitable access to palliative care for people living with IDD. So they came together to kind of form this group. At the time, it was a committee to kind of say, how do we make that better? How do we make it better for people? So there was a call out for membership, and we have about 40 members who came together. So some from the DS sector, some from the palliative care world, to really come together and start working on this resource guided toolkit to kind of make palliative care better for people living with IDD. So it's really meant to act as a supplement to the Ontario Palliative Care Network. So right now there is an existing toolkit for the general population, but we have been working on this toolkit probably since 2020 to develop this toolkit specific for people living with IDD. So the next slide is just kind of, this is what the toolkit looks like. So we start off with our executive summary and introduction, kind of tell you how to use the toolkit. And then we went on to develop some modules. So we have essential conversations. We've got domains of care, needs and norms of practice, care pathway with the health service delivery framework. So again, really aligning itself with the Ontario Palliative Care framework, how they expect things to be done for the general population, and how do we carry that over to people with IDD, loss, grief, and bereavement, that early identification piece, which is important for anybody. Pain is going to be its own module, and then symptom identification will be the next module, included with the pharmacological considerations. And we're looking at metrics, recognizing that it's important to collect that data, and then a glossary of terms, and then specific tools summary, as well as resources to the different links that we provided. So just to your right, you'll see what the modules kind of look like. And so go ahead, you're good. So each module kind of has a 3-step approach. So we kind of look at how do we identify who would benefit from that approach to care. Again, really that importance of that early identification. When would somebody benefit from a palliative approach to care? And how do we do that? By using our screening, using the validated screening tools that are specific for people living with IDD. From there, we go on and observe and assess, really looking at that holistic, that whole person care, looking at their current needs and how do we plan for the future. Pain and symptom management, again, using the proper tools to be able to screen for that. And then having those conversations and tools. And then lastly, we put a plan in how we're going to put that integrated plan together, again, with the DS team, as well as the palliative care team, to kind of help plan and manage that individual's illness journey. So we're just going to go on now to kind of go through some of the modules. We're just not going to go into a lot of detail, but just to kind of give you a bit of a highlight of what these modules look like. So the first one is essential conversations. And that's really just the importance of how do we have these conversations? How do we ensure that the plans that we're putting in place, and I think I'm jumping in on your stuff, Teresa, sorry. But how do we put a plan in place to kind of make sure that the care that we're providing really aligns with that person's individual wishes and goals? And I'll stop there. Sorry, I was on a roll.
okay. You're doing great, Janet. So yeah, just essential conversations around palliative care. And these are conversations that have not traditionally happened with people with intellectual developmental disabilities. And they're also difficult conversations, really important conversations for anybody to have. These aren't, your sit down over a drink and have a good time conversations, but they're important. And so the toolkit provides tools to help with helping it translate advanced care planning language into plain language and different tools to help people make their end of life decisions around goals and their goals of care and around healthcare consent and about their decision making. It talks about capacity and how do we manage, perceived or lack of perceived capacity or lack thereof. It also helps to give tools to help explain when you are having to be the person to break the news to a person supported that they may have a palliative diagnosis, that they are dying. So how do you have those conversations in a way that's meaningful for somebody with an intellectual developmental disability? So these are all pieces in Module A about how to have some of those essential conversations related to palliative care. The key tool in this section is around supported decision making because I'm sure all of us are on the same page when we believe that supported decision making is formal. It's a process. It's not just something nice to do, and everybody should have the right to make as many decisions for themselves as they possibly can, and provided with every opportunity to get the support they need to make those informed decisions. And so included in the toolkit is this lovely supported decision-making tool, which breaks and chunks out your decisions so that you can help talk in small pieces to the person you're supporting so they can, have the best opportunity to make a good decision.
So when we're making that decision process, as Teresa highlighted, that supported decision making is a really important piece. It's that formal process and not something nice that we do, but just to kind of help support that individual with his or her decision making. So it's a 6-step approach. So really kind of, again, looking at who would benefit from that palliative approach to care. Are they aware of their own advanced care planning and their wishes? Have we had any conversations with them at all? Step 2 is really kind of like who knows that person best? Is it their substitute decision maker? Who's that core team? Their developmental service support person. And then we want to make sure that we're avoiding diagnostic overshadowing, not kind of putting our biases aside, because Lord knows that certainly gets in the way that complicates things. We want to make sure that we want to assume that they have capacity until proven otherwise. And that helps with that whole dignity piece as well as that supportive decision making. Then step 3, kind of what is their illness trajectory? Where are they at? What are the stage of the illness is at? Are we seeing any changes? And again, seeing those changes by the use of our tools. In step 4, so that early identification piece. So there's a number of tools that we will highlight throughout the guide. And then who needs to be part of that team as that person's traveling through their illness trajectory, and then making sure that everything aligns with their goals of care as well as their the consent. So really the outcome is that we're going to have the right care, the right place, the right time, the right team, and the right communication. So steps 3 to 6 are going to be repeated as they're traveling through their illness trajectory. And again, just kind of reminders of everything that needs to be in place to kind of support that individual and their decision making. So then module B is norms of practice. Again, we want that standardized care so that it's the same care for all. So again, how do we do that? By having that early identification. So again, using the proper tool to be able to identify when somebody would benefit from that approach to care. If we have the proper services in place, we can avoid some ER aversion and really kind of have them have that care in the right place, in the right case with the right people supporting them. Again, that identification piece and that screening, using the appropriate tools that are specific for somebody living with IDD, and then making sure that our assessment is comprehensive, that it really kind of completes everything. So if we're doing that, it kind of helps with that standard norms of practice. So we have our next slide, please. Our norms of practice. So just day-to-day healthcare, we do our assessment, we do our information sharing, looking at decision making, how would we put the care plan in place, how do we deliver that care, and that confirmation, what our outcomes are. So we have actually developed a 6-step approach specific for IDD. So when we're looking at that, we'll move on to module C. So really looking at that care pathway and that collaborative team. So again, that intercollaboration team. So again, having the people who know them best, who can support them best, working with that palliative care team to really, again, it's always about that holistic care, making sure that the care that we're providing is specific to that individual's needs. So having that intercollaboration, really, how do we navigate through the different systems, making sure that the systems are all kind of talking to each other, especially when we're transitioning from one care setting to another. So if they're going from home to emerge, if they're going to hospital to home, we do know that some of our individuals do go into long-term care, so having that continuity of care for the DS to continue to support them while they're entering into long-term care. And how do we communicate? Putting a plan in place of how do we communicate so that we're all sharing the same information and really following that individual's care plan. So with this
Excuse
collaborative,
me, ladies, just for 1 second, you have a question here in the chat, if you don't mind. Sorry again for the interruption. So one person is asking, in terms of capacity, who makes that decision? This is interesting. Oftentimes, family members advocate that their loved one is not capable of making decisions, muddying the waters. Go ahead.
Absolutely. So just in general, when we're talking about advanced care planning, giving and healthcare consent, it's the person who's obtaining consent that needs to assess for capacity. And not just making that assumption that that person does because they have an intellectual disability that they aren't able to, have capacity to make decisions. But when we're assessing for capacity, it's a two-step approach. Do they understand the information that's being shared with them? And do they understand the consequences of their decisions? If I do this, this may happen. If I don't do this, this may happen. So it's really a two-step approach. Teresa, I'm not sure if you have anything more to add to that, but
there is a follow-up.
The only other piece is that if somebody truly feels that their family member is not capable, there is a formal process where they have to go through by an assessor, a qualified registered assessor, in order to have a person deemed not capable of making personal care decisions. And that threshold is very high. You have to, the person asking for a person not to be deemed capable has a lot of proof to provide. It is not something that is granted quickly, easily, or lightly.
Yeah, and then there's cost to that.
Yeah, upwards of $2,500. Yes.
Yeah.
But that's really where that supportive decision-making piece comes into play. Really kind of putting it in language that they understand to be able to help support that decision-making, right? And not just, again, making those assumptions that they're not able to make decisions for themselves, for sure.
And there is a follow-up real-life question, and this is difficult. I encountered this actually just this week. So how do we ensure that the person's needs and wishes are heard when they're about their end-of-life wishes if they do not align with the family's thoughts?
At the end of the day, it's always about the person first, right? And
should be, yeah.
So something that we have done in our advanced care plan. So we do advanced care planning with people if they so choose to, and where that has come in that very scenario, it wasn't a huge, contentious issue that they differed on. However, we had those conversations before the person got sick. So we had them when everybody was calm and everybody was thinking clearly and the emotions weren't running high. So even though they had difference of opinion, they came to an agreement on what was acceptable for this person's service, but it all based on the advanced care plan. So we didn't have to have those conversations in the moment where your focus should be the person and being with the person. So that's, if they have an advanced care plan, that's quite often because the family was aware, they agreed, they understood, and we talked it all through before it became a need. And that was by far the best strategy I've found so far.
Advanced Care Planning Canada has actually updated and made a guide, an easy to use guide that's actually simple language to be able to kind of have those conversations, start them earlier, and really kind of probing those questions about, who's the person that you turn to, if something was bothering you, who's the person that you would turn to, if you had something really exciting to share. So it's a really great resource. It's very user friendly. There's actually some cards. It's almost like a game, but to kind of help with that whole advanced care planning piece. The reality is, though, even in the general population, when you appoint somebody to become your substitute decision maker, you're really relying on them to make decisions on your behalf. And sometimes even just kind of reminding that person it's not what you would want for that person, but what they would want for themselves. And we see that often even in long-term care itself. There's things that are being done for people in long-term care who have capacity, but yet they're still turning to the family to get consent. So unfortunately, I guess that concern is kind of across the board. All right, so collaborative practice. Again, recognizing that's the next slide, please. But healthcare providers, we really need DS because DS is really good at what they do. They're so experienced when it comes to supporting people with IDD to kind of help guide practice. So healthcare needs DS, but DS also needs they need palliative care because palliative care is what we do best. DS does what they best. So how do we bring them together to kind of help with that early identification piece? How do we do that with that pain and symptom management? So kind of bringing the two together for that early identification to kind of really make sure that the choices are offering are what aligns with their preferences to really, again, when it comes to symptom management, really, making sure that we're maximizing quality of life and really trying to prevent any unethical suffering for that individual. So again, who needs to be part of the team? And again, this is just something that our group came together just to make sure that as that person is kind of traveling through the different, through the different stages of illness, that who needs to be part of the team. So when we're looking at that chronic illness space, who needs to be part of the team under the developmental service provider group? Who's that core team? Again, the person who knows them best, the person who's been supporting them, whether that be their family, is there an extended team members? So maybe behavioral therapists, occupational therapists, whatever needs to be part of that. And then looking at the healthcare team, who needs to be part of their core team, as well as the extended team. And that kind of changes throughout as that person's illness progresses. So we have advanced chronic illness stage, end stage illness. And then when we're really focusing on end of life stage, again, really emphasizing who are the people that need to be part of that team. And when we're getting to the end of life stage, really that's where we're bringing in, ensuring that the DS part is heavily involved with that, but then also bringing in those palliative care specialists to help support that individual with their care needs as well. Okay.
So this is an area where there's been many challenges. So we added in a section around policy and protocol guidance, trying to bring together healthcare and developmental services who fall under two separate ministries with two separate sets of rules, and they don't always align to make things easy. So we looked at what needs to be done to have an effective implementation of a palliative approach to care in a developmental service setting. What does that mean? What does that look like? How do we make that happen? A lesson I personally learned, and I am far from alone, is that we had policies and procedures in place based on our ministry guidelines around medication administration, but those didn't work in alignment with appropriate pain management and the type of medication administration that's required and the flexibility and the fluidity that it needed to have. We understood, but we weren't able to execute to make sure the person wasn't experiencing pain because of the policy limitations. And then the end-of-life policy, so that there's structure and guidance for how to make this happen, but how it's complicated because we've got not just the end-of-life process for the person, but we have the staff and how are they managing with that and the increased time that that person's going to need appropriate supports for. And then what happens to the 3 or 4 other people that they live with while staff are providing the additional care to the person supported. And then we layer on, quite often we're connected to families and their experience and what this is doing for them, as well as the people's housemates, and how are they coping with the fact that the person is dying, and what are those conversations? And so talking around expected death and DNRs and the coroner's role. So there's a lot of policy. So there's actually policy template as part of the toolkit to help agencies, give them the fundamentals, and then they can add their organizational philosophies and direction on how they are going to do this. But we created a policy template so that people have a place to start to make policies so that palliative care can be implemented in the developmental service sector effectively for the people that we're supporting. Grief and bereavement. Quite often, people with intellectual developmental disabilities, their grief experience is often overlooked, downplayed, and they may not be taken seriously because they display grief potentially in an unexpected or non-traditional way. But we need to make sure that we take into consideration and that everybody's taking into consideration their grief and loss experience. And that applies to the person who's palliative and the loss that they're experiencing just at the point of diagnosis and throughout their end of life, but also for the staff in the program who have lost somebody. I know for me, there's people that I've lost recently that I have known for 32 years. So that's a huge impact. It's not a how you do and then you lose the person. It's a long time in a very intimate type of setting. So there's a lot of emotion attached to that, as well as the people supported living with the person, their friends that live in other areas of the organization, and all of those pieces. There's a lot of grief, and again, families. Some families are like family to the people who are living in the group home. It's very interconnected, and there's a lot of loss and a lot of support. And how do we make sure that everybody is receiving what they need, and that we're providing that? And the toolkit does that by linking it to guides and resources. How do you do these things with all these different people in this setting? And the goal was to give tools so that we wouldn't have to figure it out all by ourselves. We would just take the tool and apply it to our situation, so you're not out there on your own trying to manage these, again, difficult conversations and emotions.
All right, so then our next module was that early identification piece. And I think that's such an important thing when it comes to palliative care in general, just to, when do we bring in that palliative approach to care? It's not just about end of life, but what happens prior to we even get to that stage, making sure that all the support's in place as that person travels throughout their illness trajectory. But what was learned was that a lot of the tools that we were using to kind of identify whether or not somebody would benefit from a palliative approach to care, these tools didn't apply to people living with IDD. And I know even some of the palliative care physicians that I work with, they recognized that the tools that they were using weren't appropriate tools, but they didn't know it. They didn't have anything else. They didn't know what was available to them. Even when some of you maybe that's my word, familiar with PPS, the Palliative Performance Scale, but even that isn't necessarily appropriate for people living with IDD. Some of them may have been, their whole entire life may have a PPS of 30%, which typically when we look at somebody with a PPS of 30%, that's really about end of life. But that might have been their whole PPS the whole time. So how do we use some tools to really ensure that we have that early identification piece, as well as gaining access to the palliative care resources? So the Pally tool is the first in its kind to really be able to help identify when somebody living with IDD would benefit from a palliative approach to care. It looks at 39 items. And what's really nice about it is that anybody can use this tool. It really it helps to kind of support that gut feeling that something's changing. So by using this tool, then that's something that you could take to the family doctor or whoever's part of that care. Say, these are the things that I'm seeing. I'm feeling like some things are changing for Johnny. What are we going to do to move forward with that? So the Pally tool would be the first tool, and then we would look at the help tool. Kind of look at, are we seeing any changes within their health? Are we seeing any changes within their environment? Any lived experiences, and then there are any psychiatric disorders. So again, kind of looking at, what's going on, And then the next step would be the stop and watch. Again, looking at, what are we seeing that's changing? It kind of overlaps with that to really, something is changing and it requires our attention. So these are the 3 tools that we recommend and that we've implemented into the toolkit to really help with that early identification piece. Next, we want to look at pain, and we know that pain is, if people living with IDD, many have lived with pain their entire lives, but unfortunately, it's often unidentified, it's neglected. Again, it's that diagnostic overshadowing, that untreated pain. There's that notion that people living with IDD have a high pain tolerance, so we don't necessarily need to do anything with it. We also know that there's certain IDD etiologies, like Angelman's itself. They have that smile on their face. So if they see that, if we're only seeing that smile, we're just going to assume that, they're not having pain. And we also know that many of these individuals are people pleasers. They don't want to kind of rock the boat or anything like that. So again, unfortunately, pain is a big component of it that is often untreated, unidentified, and all those things. So it's a significant problem. But again, it's kind of what are the tools that we use to help screening for that, for pain? So again, when we look at ESAS, it's too abstract. It looks at the 10 most common symptoms, but that's very abstract. It's abstract for most of us. How do we put a number to some of those, to some of these symptoms? 4-point pain scale might be somewhat appropriate for somebody with some mild cognitive impairment. But the tools that we highly recommend is the CPS NEID, which looks at 24 items, and you observe for them over the course of 5 minutes, and a score of 10 or greater. It gives us a 94% chance that person's having pain. A score of 9 or less lets us know that there's probably an 87% chance that individual isn't having pain. But in my mind, there's still that 13% chance that they're having pain. So maybe the time of the day that you use this tool, maybe you kind of caught them when they're at a better time of day. So I would probably recommend that you repeat it a few hours later and see if you still get that score. Because something has prompted you, something has driven you if you have concerns that this individual is having pain. So the CPS NAD is a really great tool. It's a validated tool. And then there's the DISTAT tool, which is the distress and discomfort tool. And what it does is, again, it's another tool to kind of help do an assessment, to kind of see what they look like when they're content versus what they look like when they're in distress. And the beauty of this particular tool is, it can kind of travel with them. So if they're going to appointments, if they're having to go into hospital, this tool can kind of help support the people who maybe not necessarily as familiar caring for them, to kind of be able to recognize, are these behaviors that we typically see? Are these new behaviors? So again, looking at what they look like when they're content versus what they look like when they're in distress. So the pain module is something that we've just kind of started working on over the last few weeks, but we're moving along with that. But we recognize that it's probably, all of the modules are quite important, but pain is really something that we want to make sure we get right. And then again, when we're looking at the pharmacological considerations, so again, we know that people with IDD are very sensitive to medications. Some of these individuals are high metabolizers, where they have that bioavailability, so where maybe they need less medication, or some of them have low bioavailability, where maybe they need more of that medication. So really being mindful of that, really being mindful of the side effects of it, and then really kind of, how we prescribe medications, again, kind of really looking at all of their IDD etiologies, as well as kind of just like their physical stature and their physiological function, because that might look a little bit different than that of the general population. So again, making sure that we're using the linking with the pain and symptom guides, again, using those proper assessments, and making sure that those end-of-life order sets are specific, because again, we have to be somewhat cautious, especially when it comes to opioids. There's high use of antipsychotics, so really being mindful of all of that and how that impacts that individual. Our next module is module G, so really looking at symptom management. So these are just kind of some of the things that we highlighted. So again, looking at dyspnea, so there's high incidence of that. There's high incidence of seizures or epilepsy. Again, looking at those behaviors, and are those behaviors a change from their baseline? And that's what we're always looking at. We're always comparing things to the baseline. And then lastly, looking at that frailty piece. And we see frailty in the general population, especially as people start to age. But people living with IDD have their own specific IDD frailty. Frailty can be from the time that they were born and on. So that frailty, it looks a little bit different. And we actually have been working on a tool specific to be able to help identify that frailty and how things will look different for that as well. So those are the things we want to be mindful of. We also want to be mindful of mood screening. So we've got the Glasgow Depression Scale. as well as the Glasgow Anxiety Scale. And again, looking at are we seeing depression versus whether or not we're seeing dementia. And that can be really somewhat challenging to differentiate people living with IDD. We know that depression is a common symptom and often undertreated as well. Often they'll have 1 to 2 episodes of depression before that move kind of helps that precursor to that dementia piece. So there's the two there, but they also have the picture-friendly ones to kind of be able to use for people living with IDD. A score of 13 or greater indicates that they're having depression, and then a score of 15 or greater indicates that they're having anxiety is an issue. So what's really nice about us is they have the IDD-friendly picture versions. And then we've also included the NTG, which Paula has done such a great job of explaining to us. I won't go into a whole lot of detail about that, but again, it's another tool that we're trying to identify whether or not that person with IDD is starting to develop dementia. We know that there's a high prevalence of Alzheimer's as well as dementia, earlier onset with a much more rapid progression, especially we know that Alzheimer's accounts for about 40% of people living with Down syndrome. So the recommendation is that for people with Down syndrome, we do this NTG at the age around 35. For others, we do it when they're in their 40s. It's recommended that we do it annually just to kind of get that baseline. For somebody maybe with Down syndrome, you might want to do that every 6 months, just to kind of keep that pulse. Again, we're always kind of looking for those changes. And then lastly is our metrics. All of this will be for nothing if we don't gather that information. So really, how do we look at the OPCN, Ontario Palliative Care Network, and Health Quality Ontario, looking at their metrics? And how do we measure if anything we've done has had measure of success? So a lot of the tools that we are the questions that we put together to kind of be able to gather that data aligns itself with the caregiver voice survey that is often distributed through the Ontario Health at Home. So again, it's really kind of being able to gather that information, seeing if we're making changes, seeing if we're seeing improvements, and at the end of the day, we're making sure again that that we've actually met their needs and not just assuming that we have. So metrics is a big part of what we want to do as well. And then I think it's back to you, Teresa.
So this toolkit includes many components, each designed to address areas of palliative care that are currently ineffective for people with intellectual and developmental disabilities. By bringing together developmental services, healthcare, and palliative care providers, we can bridge the gap and create an environment that supports the best possible palliative care for people with intellectual and developmental disabilities across the province. The toolkit's in its final stages of development, and once complete, we will share how you can access the tools that we have talked about today. And we have a bit of a saying that's been used in multiple presentations. If we get palliative care right for people with intellectual and developmental disabilities, we get it right for everybody. So thank you.
I'm going to say thank you too. It is, you know what? I think that my mind is aching right now. You have done such a fabulous job, and what a well put together toolkit. I'm hoping that everybody can take advantage of this when it's finished and ready to go. I think you have covered every single base and every single, moment of what if. And taking that guessing out of the work that people do really helps us support the people and keeping them at the center of all of the work that has to happen. It's amazing. It's really amazing. I don't know about other people on the call, but my head is spinning with tools right now. We knew it was going to be quite a lot this afternoon, when we were talking about the different resources and different guides and different tools that people can use and apply. It is overwhelming, but I think I'm really heartened that the work's being done to help all of us step in the right direction. And I'm hoping people are feeling more supported than ever before. Right. Thank you very much, you two. I am going to turn there's a couple of questions here. Just a second. Ask for questions, and then I'm going to turn the closing comments over to Andrea Rutherford. Oh, okay. Jean-V found this quote in the Canadian guideline, which you shared. A good death means a death that minimizes pain, involves preferred supports and caregivers, and honors preferences, values, and plans made earlier for last days and post-death rituals and practices. That's lovely, Jean-V.
And I think it just aligns itself so well with just that quote from Cicely Saunders. It's
Absolutely.
exactly that. So thanks, Jean-V.
Absolutely. Absolutely. And I like all of today, actually, because I think we're honoring people where they are, honoring people as they're changing, and honoring the workers that are supporting them. Oh, and that's going to be an amazing tool. I can't wait for it to be shared. Absolutely. I echo that.
And our
Yeah.
hope is that once it's available, that people will actually be able to save it onto their own websites as well. So they're not going to have to go looking for it. They'll just have it readily available at their fingertips.
Nice. Readily available for all of the teams. You know, you kind of want to have a practice go with all of these tools, don't you? Right? Okay. Now, Andrea, I just have to do my find a participant here. Andrea Rutherford.
And Teresa, while you or Paula, while you're doing that, I
Yes.
want to say thank you. I've learned a lot from everybody today, but really stuck out to me in your presentation, Teresa and Janet, that the importance. I'm glad you highlighted the importance of all healthcare professionals really understanding the trajectory of the needs of the persons living with individual developmental disabilities. And I've learned so much from community teams and working with Teresa and Community Living Dufferin, and from the teams, but also from the clients that you serve. And I think it's really important, like you say, to be comfortable knowing the person and to be knowledgeable for us, coming in from different sectors, because we don't have expertise and skill in your area. And it's fairly new over the last few years for us to be doing this, but getting comfortable with knowing the different diagnoses and being comfortable with the palliative care approach. So thank you both.
Thanks, Elaine.
Learning and growing for everyone.